Good evening, ladies and gentlemen. Welcome back on our weekly webinar on ERCP and US. And this time we are dealing with a very important topic, and that is reprocessing of ERCP equipment and endoscopy accessories. You all understand that we are living in a society, in a community where the cost consciousness is very high. And in this scenario, we have to be extra cautious in terms of transferring the cost to the patients. Now, if on one side, we have the uh, brand new accessories where we can have lesser uh, uh, problems for infection and better results. But at the same time, they are very expensive and the cost is quite prohibitive in quite a good number of patients. On the other hand, when we are reprocessing our accessories, it is always linked with more number of adverse effects. And for that, I requested Ajay Kumar, Dr. Ajay Kumar, who is chairman BLK Institute of Liver and Digestive Diseases, ex-president of Indian Society of Gastroenterology, and a very renowned name in the field of ERCP and advanced endoscopy. He has been very kind to spare his time on to for the Pakistan Society of Gastroenterology and Asian Endoscopic Ultrasound Group, and for the benefit of the audience in Pakistan. And I'm really thankful to you, Ajay. All
My
yours.
thank you at the outset. Special thanks to Dr. Tayyab and Dr. Saad. Give me an opportunity to be with you all. I have been to Pakistan a number of times, and it's always been a pleasure. Few of the best food that I have was in Lahore. Uh, so the topic assigned to me today is a topic which is very important and very dear to my heart, very close to my heart. What is the issues involved in reprocessing of an ERCP equipment and endoscopic accessories? The balance between the risk of infection and the cost issues and the efficiency issues. All the three factors are combined there. Because it's focused on ERCP and because there has been a huge controversy over the last 6 years or 7 years on the duodenoscope sterilization. So my first part will be on the endoscopes. And the second part, as the time permits, I'll speak on the endoscopic accessories, especially what we are looking at from the Indian point of view. And I'm sure that applies to Pakistan as well. So let's start. What is the actual risk of infection or a transmission on GI endoscopy? Before we go on to that, let's understand three things. That the CDS of endoscopes. C stands for cleaning, which is the manual part. Physically remove the organic matter and contaminants. Then comes the disinfection and sterilization. We should understand the difference in the two. Disinfection is to kill pathogenic microorganisms, while sterilization is to kill all microorganisms. Disinfection does not kill spores. This is a very famous table, Spalding classification. Whosoever goes into a disinfection process looks at that, which defines or divides all the equipments into, on the stages of disinfection into critical, semi-critical, and non-critical. And it depends upon whether it comes in contact with only skin or mucosa, or it penetrates the skin and mucosa or the vascular space and the cavity. So because the infection risk depends on that. So what is recommended today is that critical sterilization to be offered to the critical the equipment has to be sterilized, and semi-critical can undergo high-level disinfection. If you note here that the high-level disinfection till today, what we are practicing is for the endoscopes, while the endoscopic accessories are supposed to undergo sterilization. So endoscopes, as they are heat labile, and semi-critical devices. So therefore, they go disinfection, undergo high HLD, that's which is basically a terminology for the uh, uh, disinfection. Now, sterilization destroys all microorganisms and eliminates bacterial spores. We all know that autoclaving is the best method, but then there are ethylene oxide sterilization, and then there are other newer methods of hydrogen peroxide gas plasma, ozone, and vaporized hydrogen peroxide. And now people even talk about low temperature sterilization because to the equipment which can be damaged by sterilization. High level disinfection destroys all types of microorganisms. And here you use the germicidal chemical germicides, liquid chemical germicides, uh, like Sidex that we've been using routinely. So with this background, what are the basic steps to clean and perform high level disinfection? Please note here that first thing starts in the endoscopy room, and then you go to the disinfection room, and there the most important thing are the two, that is the manual cleaning and the seventh point, the drying. Because these particular steps, rinsing, high level disinfection, and again rinsing, all these now in the automatic processes comes automatically. But the manual cleaning is a totally individual human dependent. And so drying is another thing that people talked about, that if you use alcohol for drying, then it leaves a lot of lacunae, and it should be a storage cabinet, and you hang the scope there and let it dry. So this data that I'm showing you is for the all sorts of endoscopy. It's not for the duodenoscope. This is a wonderful review by Speck et al. Published in 1993, which they have 265 articles, and they reported about 281 transmitted infections. That is about 1 in 1.8 million procedures, and the clinical spectrum ranged from colonization to death. So a very minuscule risk involved of any serious complications. And then they went ahead and tried to find out what was the reason for all this. That is easily either the inadequate cleaning, that you don't clean all the channels of the scope, or it's an inappropriate or ineffective disinfection, that the time exposure is less to the germicide, or the perfusion channels is not done well, or test concentration is not good, or the failure to follow recommended disinfection practices. People have been using tap water, then you have to use the sterile water. The way you use the water in the dialysis unit, same way you have to use it here. So associated, most of these infections were associated with breach in currently accepted cleaning and disinfection guidelines. So the focus was that you should follow your sterilization or cleaning protocols in a proper way, so you will not end up this problem. But the things started changing, though there were reports of Pseudomonas and Klebsiella earlier on. But in 2014, the first report of a carbapenem-resistant Enterobacter, and that's what it changed the thing. And I'll go straight to this first report, which is from a suburb of Chicago. And first and the largest US outbreak with a New Delhi metallo B lactamase. You know, this is a enzyme produced by the E. coli, which makes it carbapenem resistance. And that's the reason the word comes as CRE, carbapenem resistant enterobacteriaceae. Or it could be E. coli, it could be Klebsiella or Enterobacter. And so this was, initial one, was a carbapenem resistant E. coli from a contaminated duodenoscope. And then, of course, since then, they have reported, then they have looked at the back Pseudomonas infections, total 7 outbreaks in US. They reported total 67 cases, 18 deaths. If you look at the overall, the total number of ERCPs done every year, there is around 3 lakhs. So that number may not be too big, but then still this is a significant which can be fatal. And same way, you had it across the world, main reports from Netherlands, France, Germany, and so on. So what is new in this new outbreak? That bugs transmitted were far more drug resistant and dangerous. And more important than that is that they're also traceable. They could be traced. You know, if you have to go into the details on which they investigated those, and then this forced the FDA's intervention, and then there is uh, a Senate report, US Senate report, which showed more than 25 outbreaks of the multi-drug resistant organisms with duodenoscopes. Almost 300 clinical infections with 30 deaths. This was transmitted despite appropriate high-level disinfection. And all, it was not restricted to a particular company's endoscope. All three, Olympus, Pentax, and Fuji, have reported all this. And so this was attributed to persistent contamination at the elevator region or the cable channels. And in all these episodes, manufacturers failed to notify users, hospitals were slow to notify the regulators, and FDA's failure of regulatory oversight and safety monitoring were recorded. And there's a global map, but then there was a huge noise. If you look at the newspapers, undisclosed superbug, second dozens. And not only that, superbug infected spouse, widow told over a year later. So this obviously created an outbreak. In the last 7 years, there has been a huge work on that. And last month, American Society of GI Endoscopy's Infection Control Summit, this was actually held in December 2019 and published in 2020. Then this is the summing up that 7 outbreaks of MDR related to ERCP in USA. Culprit organisms are often normal gut flora. Clinical infections often distal to the site of infection, like urinary tract infection or pneumonia. So they're not exactly at the same site where the intervention was done. And there is a lag time. The first case which was reported, the procedure was in February, the case infection was in the month of November, December. It means that colonization occurs and some of them get infected. It can carry on silently. Duodenoscopes are often culture negative. And in all these cases, they have went back, they did not find the failure of the prescribed reprocessing protocol. So that's important. If you remember earlier, I said that most of the infections in the endoscopy related infections were attributed to the failure in the protocols of the reprocessing. But when you talk about this CRE outbreaks, in that centers had meticulously followed the reprocessing protocols. And contamination rates were 0.9 to 1.9%, attack rate of 18.9, that is 1 in 106 or 1 in 2,632 is likely to get. So this raises a question, it's a New York Times headline, why are these medical instruments so tough to sterilize? Well, we all come into the second part now, that we know that there is a problem. And now the question is that why you are following the protocols. So where is the problem? That endoscopes, duodenoscopes, by itself, they are complicated. Now this itself is very complicated, but this is common to all the endoscopes. But what is different in duodenoscope, that there is an elevator and there are wires which are, I don't want to go into too much of mechanics, and there are different, these are the spots, these are the wires of the elevator, and this is the area behind, this is the, if you look at this, that this is the elevator. And the area behind it, these are not easy to clean. And cultures from the duodenoscope were positive for NDM producing E. coli from the elevator channel. This is the elevator channel. And there was no identified breaching, the reprocessing, as I said earlier, and compatible cleaning brush, but not on the manufacturer list. And so the possible mechanism is that the fixed distal cap failed to hamper cleaning and disinfection. And this O-ring, which is provided there, it may not seal forceps elevator axis sufficiently. These new duodenoscopes were then withdrawn. And not, so this was the see this thing. And if you look at this is the camera, and is the lens, and then this is here the elevator, and behind the elevator was the area which is not biofilm forms. And this biofilm seen under the electron microscope looks like that. And these biofilms are due to the micronutrients, and they became the right medium for the infection to grow. So the bacteria grow over that. And so that's what is, what was the conclusion? That because these are complicated designs, so the manual cleaning is not able to clear the biofilm, and so is through the channels of that. And that's why this problem occurs. In Amsterdam, an elegant study, they actually sacrificed from the 73 Dutch ERCP centers, they sacrificed the 2 duodenoscopes in each center, and then they sectioned each endoscope and checked for the microorganisms. And they also confirmed all that the 22% duodenoscopes from 39% centers were contaminated, and 15% duodenoscopes with a MGO multiple bacterium, Entero E. coli Klebsiella. And contamination was not, again, the factor, it was not duodenoscope type dependent. What I mean by that, it was not a manufacturer dependent, it was not a Olympus, Pentax, Fuji, all 3 equally responsible. So the conclusion from these studies was that the present reprocessing and process control procedures may not be adequate and safe. So then comes, what is the solution? The solution, two people have been talking about it. I don't think we have found a final solution, but I will touch upon the various issues which have been thought about. They said, focus on the manual cleaning, and I'll talk about that. Or you go from high quality disinfection to the different ways of sterilization which scopes can tolerate. Or you alter the design of the scope, you add on the caps, or the disposable endoscopes is the final thing that they're talking about. In manual cleaning, we all understand, we talked about this cycle right in the beginning, that duodenoscope is immersed in the enzymatic detergent. So, before that, wiping external surface of the duodenoscope and irrigation of working channels using enzymatic solution. And the irrigation of working channels and suction port after the immersing in the disinfectant. Now, these are the charts that I have taken from the Olympus company. And this tells you that how much time each person has to devote. The technicians have to be fully trained and supervised. That after the initial thing, then you have to brush the distal end of the endoscope. And you look at this, that it goes behind the elevator. This is the forceps elevator and the forceps elevator recess, which has to be brushed from the different directions. And then the left side distal, left side surface, right side surface, or the back side surface. So this is the most important part of the whole manual cleaning, which has to be done meticulously. So you have to devote about 10 minutes to that. And then of course, the flushing the various, first the brushing and then flushing the various channels, which can be taken up in detail. And after that, the scope goes into automatic reprocessing, and then again rinsing with a filtered sterile water. It is not the tap water. It has to be the filtered sterile water. And then next step is dry, which I mentioned earlier, that now there's a thought process that you should not be using alcohol for drying. It should be allowed to hang in the storage bank and should dry with this time. So what happens with this? That you have to keep it in the closet for use. You need time. You need time. If you have only one side viewing endoscope or one duodenoscope, then you cannot put your ERCPs immediately one after the other without putting a gap of at least an hour. So you have to have, if you are to doing more than that, you need more than that, you need to have more scopes so that there is a time gap between the two. And that's very important for the health establishments to provide. So after we talk about the manual cleaning and this thing, then we come on to that from disinfection, can we shift on to sterilization? And these are the various methods of sterilization. Ethylene, ETO we know, but the problem with all these methods is that they cause damage to the scope. If you look at this, that the 4 out of 6 duodenoscopes were definitely damaged in this study in 2016. So you have to find the safe ways to sterilize, but that also cannot take place of the manual cleaning, which is very essential. And this is a duodenoscope reprocessing practice patterns in US endoscopic centers. And if you look at their viewpoints of the physician, 60% of the physicians believe that redesign of the endoscope is the best long-term reprocessing solution. And this particular thing, I mean, out of all the people who have responded, if you look at the scope redesign, because if you redesign the scope, then you do not change your current practices of procedures, protocols which are going on. So maybe you have to improve the tip or the duodenal cap to make sure of that. Of course, there are people who are talking about disposable instruments and all that. We'll touch upon that as well. So the FDA is recommending transition to duodenoscopes with innovative designs to enhance safety. And this is the FDA's safety communication. They believe the best solution to reducing the risk of disease transmission by duodenoscope is through innovative device designs that make reprocessing easier, more effective, or unnecessary, and less dependent on the human error. And currently, there are some designs are available which will show none of them is perfect. You have a Olympus removable tape, you have a Pentex disposable cap, or with an elevator, and so on. And the stores is another one. This is the type of cap that you have, disposable cap, which you can change from procedure to procedure. And the other innovation on the way, which is published last month in GI endoscopy, in the last abstracts in the DDW, which was not held physically, this was a very good abstract by Pankaj Pasricha from Washington, DC. He showed this particular thing, that this is how this particular sheet comes. This is an applicator, and this is the actual sheet. And when you apply over the scope tip, this is called scope seal device. This is supposed to seal the channels so that this microorganism or the biofilm is not formed. So this is the working channel extension of the same scope seal. If you look at this side view, that this is the way the scope seal comes and applied here. And this is a one-time use, and this can be disposed of. It does not increase the cost to the same level as other. The price of this is not fixed as yet. It is still not available for the regular use, but this study done elegantly has looked at a number of things. It has looked at that when you apply this seal, it does not compromise on the quality of the endoscopy, quality of your images. It has shown that leakage, it does not show any leakage into that. It shows there is no collection of the microorganism, and so it shows that the disposable device provides two-way protection to the duodenoscope, from microbial contamination without the potential for disrupting current equipment, technique, and workflow. So quite promising, but I think it has to be validated by the different centers and then price has to be competitive or maybe affordable so that it doesn't add much to the thing. And while we are talking about the different sterilization methods, people have gone on to develop disposable duodenoscopes, and there are two duodenoscopes, disposable ones, which are available. And there is a study which has come comparing the different characteristics of disposable duodenoscope with the three existing standard duodenoscopes, reusable duodenoscopes, looking at their vision of angle of vision, field of vision, and their elevation and success of the procedures and so on. And the initial trial has shown that they are competitive. But the question is, we may talk about these disposable devices. Maybe the sitting in the Western world where they can afford to do that, maybe even they cannot afford, but then they are more worried about a lot of other issues. First question need to be answered, does it have the same quality? But the most important is, can not only we, can anybody afford it? Who will pay for it? What about the medical waste? All the scope, people are talking about the biological waste today, what is existent, but how much this will add, we are wasting the total scope. How will it go about? And how do you prevent the recirculation of these scopes? I mean, how do you prevent the reuse of these scopes? How do you avoid the export to the third world countries? For this, I will suggest read the editorial by last month editorial by Guido Costamagna from Italy in GI endoscopy, who has touched upon these issues in great length. And then which patients to use it for? How will patients react to the availability of such a product? This concept has been addressed by Shyam Varadaraju, a concept of disposable duodenoscope at what cost? They have, in endoscopy news, they published that they said maybe the low volume centers, emergent out of hours off-site procedures, immune suppressed like post-liver transplant or patients on immunosuppressants or cancer therapy and high-risk cases, or patients who already harbor multi-drug resistance so that you don't infect the other patients. So friends, when I'm coming to the end of my talk on the endoscopic disinfection. And here the take-home messages. Contaminated duodenoscopes are an infrequent but important cause of outbreaks of CRE and other related superbugs. Outbreaks observed despite appropriate reprocessing. Infection occurs with duodenoscopes from all three manufacturers. Enhanced training and monitoring of reprocessing staff is required. And whenever you have this thing, one should report to the medical watch. Research encouraged for improved reprocessing and endoscope design, and zero tolerance for duodenoscope transmission of infection. I think that's the carry home messages. I don't think we have a final answer to that. We have found a final answer, but whatever is going on around the world in this area, I've tried to sum it up. Whatever you say, I have a brief presentation on the endoscopic accessories. I can break here, answer the questions, or I can straightway go on to that. Whatever you ask me, I'll do that.
Continue. I shall request that you need to continue with the second part of your presentation, and we can have the question answer session later.
Right. So this is based on the focus on the accessories, endoscopic accessories. We are in the era where everybody is trying to sell us the single-use disposable accessories. And all the societies across the Western world have recommended that these cannot be reused. Like to address by this issue by looking at three factors. The cost involved, environmental hazards, and what is the prevailing practices despite even in the Western countries. If you look at the cost of therapeutic endoscopic procedure, in the Indian context, this is slightly older slide, but today it will cost about almost 1 lakh Indian rupees if you have to do a therapeutic ERCP. And if you combine it with a mechanical lithotripsy or a laser lithotripsy by spyglass, the cost is further prohibitive. So question comes, patient acceptance of surgery versus endoscopic cost. And if you look at the Western uh, calculations, they say that disposable equipment accounts for 68% of the procedure reimbursement. And if you look back at this slide, that average cost of a therapeutic ERCP in our country is around 25,000 rupees. So where does this 75,000 rupee come from? Who will pay? Can our patients afford to pay? Are our insurance companies ready to pay? Where even if it is covering only 2% of population. So the second part, after touching upon the cost, the issue is that the environmental issues. While the medical disposable industry may benefit from labeling devices as single use only, we all bear the cost of subsequent disposal and pollution. This is from America, this is not from India. And endoscopic prevailing practices, I mean, I've tried to be very brief, I'm not giving too much of data here, that in endoscopic accessories reuse, the single-use medical devices are often used several times. This is New York Times in 1999. And in an informal poll in USA, out of 200 endoscopists, 30% reuse single-use cannula and 17% reuse single-use papillotomes way back as late as 1997. So please see that even though the laws are so tough and harsh there, even there in the so-called developed countries, the cost factor is high. Prevailing practices are different. So what are the practical problems? If you look at the three issues which come into picture, that is, can the reuse accessories transmit infection from patient to patient? Two, will they be working as efficiently in the patient number 5 as efficiently as in patient number 1 where that accessory is being used? Say, for example, a sphincterotome. And thirdly, where do we stand in a legal manner? So based on all the elaborate study, there was a task force set up by the Endoscopic Society of GI Endoscopy of India, which I had to chair. And we came out with a position paper with the recommendations based on the data. And certain data was present, certain data was not available, but I'll talk. So what we said, we made the statements to looking at all the things, that endoscopic accessories can be reused after proper sterilization. The word is proper sterilization. This is something which needs to be checked. And of course, we all know what is the sterilization process. I am not going to the details of that. Now, what is the requirement? If you are recommending that, so what is the requirement for that? That staff has to be adequately trained and certified in reprocessing accessories. Smaller centers not having the facility for sterilization should share with bigger organization or pool resources to set up the facility. And all third-party processing facilities, if they are not available, they can be made to function once you encourage them, can be available. And once you allow that, you have to have a quality control. And quality control requires regular audit of the adequacy of sterilization. And this is something which is based on the hospital infection control cell. And what we do is that we are, every accessory undergoing sterilization, the cover has the full history of that particular accessory. That this has been opened on this date, first time. It has been used in so many procedures, and so that you know that how long you're using. Because that comes into the picture when we touch upon the second issue, that is the mechanical failure. The number of procedures for which a particular accessory can be used should be decided beforehand to ensure adequate functioning of the equipment and to prevent breakdown or less than adequate efficiency during the procedures. Huge data are available for a number of things like the biopsy forceps, like the double channel sphincterotome, the guide wires, but we do not, all this data, I must say, came from USA. One from Dick Kozare, and past president of American Society of GI Endoscopy, and one by Cohen, which he actually done the nice life analysis of the lifespan of the sphincterotome. And they came out with certain numbers. They checked the functionality or the efficiency of each sphincterotome after everything, after every procedure. But we do not have this particular data on number of new accessories. Like we don't have it on endoscopic US needles. We have one study from our center we published about 4 years back, which shows that there is a colonization in that. It should not be encouraged to reuse. Same way, triple lumen sphincterotomes, we don't have any data on that. And that's where the data can be done. So the rough guidelines are based on our experience. Now, these are also rough. Actually, we need more efficient data on that. Sphincterotome 7 times, or if wire breaks or does not bend properly. Guide wire 10 times, or till it breaks. The only problem with that is the tip of that hydrophilic wire may break inside and may stay there. And that's the reason you have to put a number of times. Baskets, retrieval balloons will not cause any harm, except for they will delay the procedure. So they can be used till they break. Biopsy forceps, till they break or do not bite well. Each accessory pack should carry usage history, that how many times it has been used. Lastly, the legal issues. That is an issue that needs to be addressed from country to country. For this, we should have a hospital infection control committee's approval, and every hospital is using it. In India, 100% centers are reusing the single use re-accessories, and they should certify the sterilization process. And patients we should take the informed consent. And if we go ahead, we have two different charge lists. If you are using only the single use, then pay different. If you are paying for the reuse, then you pay different. If so, they have to write that and have. So the adequate number, what is the requisite? If you go for this policy, that you should have, say, you're doing say 6 ERCP procedures in a day. So you should have a adequate number of accessory tests should be available, because you have to sterilize properly. You can't keep on reusing them on the same day. It will not justify the sterilization process. And ideally, 3 times the number of procedures carried out in the unit per day should be available in the unit at a particular time, so that your circulation is maintained and you're not short of this, or you don't have to cut corners for that. So I will sum it up by saying that debate is not whether to reuse or not, but how to reuse effectively. And for that, sterilization, optimal quality control is must. That's what is required. Thank you very much. I'll stop slide sharing. I'll be too glad to take up any questions if there are any.
Thank you, Ajay. A very nice talk, very elaborate. You have covered almost everything, and something, lots of points which are close to our heart, especially when we are reusing the accessories. I understand the ground situation is roughly the same as in India, in Pakistan too. Almost all the centers are reusing the accessories, and the last comment that you have made, that it's not a question of using or not reusing the accessories, question of if we are reusing the accessories, how best to use them. And your comment is very valid, your message is very pertinent, and I think very precise. There have been certain queries from a few of my colleagues, especially the people, ex-students, colleagues that work in UK and America. Whenever they come back from there, they bring lots of their expired stuff. And they have a moral guilt at times, and then they have some legal issues with them. Should they be bringing those accessories? And on our side as well, should we be using those accessories? Although I understand that since they are packed accessories, all we need to do is that we can re-sterilize them before carrying out the procedures, but otherwise there should not be an issue. What are your comments on this?
So what I understand rightly, that question is that should we be reusing the accessories or the legal
No,
issues?
the packed accessories that they bring, although they are expired, the expiry date
Yeah,
has been
about
put on
expired
sale.
accessories.
Yeah.
Sometimes, overseas, a lot of things are thrown away, just short expiry. And so they are, our colleagues sometimes obviously get them. Some of them are very expensive. Some are not available here. And so, you get them, you can re-sterilize and use them. Is there a problem with that?
I think the same principle applies there at the reuse of accessories. I don't understand the concept of expiry of these. I think the expiry basically tells you about the sterilization expiry. It doesn't talk about the equipment getting expired. I mean, even in the medicines, which are basically chemicals going inside the body, there also people say that even after the expiry term, is the effectiveness may come down, but then it doesn't harm, right? Most of the things are like that.
Ajay,
So in these, I don't, yes.
sorry.
Yes, sir.
Go ahead, complete I totally agree with you.
Yes, but so I think that it's basically they can be reused after proper sterilization. So I think
Ajay,
the focus.
my question is ERCP or endoscopy a sterile procedure? We are talking a lot about sterilization here. Is the procedure sterile? You're going through the mouth. You in your slide initially you showed that initial study showed that these were normal commensals that actually went with the scope inside the system wherever you went. And no matter what you do, you can't make it a sterile procedure. You're going into a non-sterile field. So that is one of the things that's bothered me. And again, with these disposable scopes, which I know is not because of more, I may be wrong, but I feel more because of financial benefits than benefits to the patient. And the list that Shyam, you showed, I'm not too sure these disposable ERCP scopes would be ideal for someone with post LDLT or difficult cases. I haven't used them, but I don't know. So what are your views? I mean, this is a non-sterile procedure, and we talk a lot about infection. How do we take care of that?
That is a very interesting and a very good question and a good point of discussion. Is it a sterile procedure? Obviously, we are going through the lumen, which has bacteria. Why we thought it is sterile? Because you have a acid in the stomach, so you're going through that environment, and maybe there is some contamination there. And even otherwise, after you're done a sphincterotomy, there has always been thought about of ascending cholangitis from the bowel. So how can it be 100% sterile? The thing is that when there is a free drainage and there is no problem, so this does not cause harm. Problem is when you face with the resistant organisms. We are living in a world where the antibiotics are used left and right indiscriminately. And you talk about this carbapenem resistance bacteria, and these are fatal. So why it has taken 50 years to come into the limelight? Because probably these are fatal bacteria. Even that time was not so prominent in the clinical picture. So that's the reason it has become important, because these can be life-threatening. And there is a thought that probably these bacteria come from doing ERCP in the patients who are suffering from CRE. And those who are suffering from CRE, so you are not able to sterilize them. That's the reason you are introducing it. That's the reason it becomes important. So your point is valid, that it is never a sterile procedure, 100%. But the question is, at what stage it causes harm to the patient? So we have to accept that reality, that yes, it is harmful in a patient. If it may be minuscule, but then we have to look at the costs involved, the overall benefits of that. The fact is that ERCP is the treatment of choice today for managing CBD stones and malignancies. And that is, even surgeons agree to that. And we do not have a better modality to treat them. And there's a huge, huge number of the patients who require this. So how to make this procedure safer is the thought process one should go on. That's
no, fair enough. I think the second point, if I can quickly raise, is the number of times you mentioned that one can use the accessories. we monitor all the use, all the accessories that we use. And the numbers on average, we use a sphincterotome, and we're talking about triple human. We use about 5 to 6 sphincterotomes in a month, and we do about 100 to 125 ERCPs in a month in our unit. Our success, like you said, I mean, obviously when the wire breaks or the cannula tip becomes really obviously not right, we continue using it. And with the wire guided technology, it has become even more easy, because even if the tip is a little bit. So I think, you know, because we provide free service, and you know, so it becomes very difficult. I don't know if we are doing the right thing or not, but that's what is happening now. Change that scenario completely to a disposable, like you mentioned, disposable accessory unit. Convert our unit to a disposable accessory unit. From 1100 plus ERCPs a year, we'll come down to maybe 100 ERCPs a year, maybe. And so to me, that's the issue with disposable accessories. It's about providing the service. Now, the other thing I wanted to ask you was, the studies, I went through these, but I couldn't see the numbers. Are these drugs, the different spreads that have been mentioned, are these specifically in patients who had biliary obstruction and they were drained or not drained? Or these were just standard ERCP stone extraction, and there was no difference between the improperly drained versus once it's completely drained? Do you have any idea on that?
You see, there is a one study which has tried to evaluate the high risk factors, and in that stenting was one of the high risk factors. So these are all therapeutic ERCPs. They are hardly ever does a diagnostic ERCP.
No,
so
what I meant was stone versus stent.
But the biliary stenting has been mentioned as one of the high risk factors. But see, if you look at that, the number of cases in each outbreak are very small. So it's a compilation of the data which has been shown that this is a high risk factor, but it's too early to pinpoint that. But obviously, one expects that in obstructive biliary tree, the chances are more likely. I agree with that.
I think you're perfectly right in saying it, because there's so many ifs and buts whenever we are talking about stenting and infection. If the drainage is good, if the drainage is appropriate, the infection is not going to be there. When the stress is there, when the drainage is not appropriate, infection is bound to happen. So there were lots of ifs and buts. We cannot say it for sure whether the data which has been projected in the literature, is it really applicable to all the patients or not? For on that context, may I ask you, has there been any work in the India on this account, especially on two things? Number one, the infection rate of the endoscopes, the swabbing of the tip of the endoscope, and the kind of bacteria that have been colonized over there. Number one, and number two, the any controlled study between the disposable accessories and reuse of the accessories in terms of infection?
No, the India, there are 2 or 3 studies on the use or reuse of the endoscopic accessories. One was on the biopsy forceps, the other was one on the sphincterotomes. But not comparing one with the other, but it's just that it has shown that they were safe. As far as the study on the colonization and all, since the advent of corporate hospitals since last about 25 years, the actually hospital infection control cells are very active, and we have a standard practices, and we are very, and in the last 10 years, we have become more conscious of the disinfection processes as our therapeutic endoscopy work started increasing. So people became more conscious of that. And we actually shifted to automatic reprocessors of almost 15 years back or so. And no, earlier on, if you remember, when we started the whole endoscopy work in all government institutions and even in private setups, it was all a Sidex and plain tap water which was being used for the sterilizing. But now most of them will have a automatic reprocessors, separate dedicated areas for disinfection. And that has become the actually most important. I wish I could show you my new area of disinfection, which we have put a lot of stress. We have got a special storage boxes. We have got about 4 ARE machines, And so it's a very divided division between the clean area and the dirty area. So all those things are taken into consideration. Absolutely, the air filters, and then the exhumes have to go on the right way. All these things have become the part of the hospital design. But and every week or every week, our hospital infection control cell is collecting the samples from the scopes. And if there's anything positive, in the last 1 year, we haven't had any positive report to us, because we come into picture only when they pick up some positive culture and then they report to us. So we reject. And
Yeah.
we have made compulsory for our endoscopic staff. I organize once a year in-house reorientation or something like CME like thing for the disinfection procedures to the whole staff, to keep them on the they have to be told that they're on the notice, they have to be working on that, otherwise protocols are bound to be broken. We are all human.
I think Ajay, that is a really an excellent thing to do, and certainly we'll pick that one up from you. We have actually we do this in our courses, because we in every course that we run, including ERCP, there is a cleaning part of the course where we show the attendees or the fellows or trainees the way to clean the scope and the issues with cleaning the ERCP scopes and accessories. But I think you're doing a CME every year would be an excellent idea, and that's something that I'm sure the Society of Gastroenterology should look into. Ajay, do you know what is the percentage of infection, post ERCP infection in generally in India? What is the range? And are you getting multi-drug resistant organisms as well? And if you do, what's the percentage?
That we have don't have any reported cases, but I'm sure it will be there. It's not possible that it won't be there, but we don't have any reported data till now, and and there's no published data on how much is the positivity in these cases. So I cannot comment on that. But that doesn't mean that it exists just because.
But in your experience, Ghyas and Ajay both, do you think the risk of cholangitis, the risk of infection that we see here, is significantly higher than what's reported elsewhere?
So I think what I understand is that if you're able to drain the duct properly, there's no risk of infection. The risk of infection is only when you fail to drain the duct properly. My opinion on this account is that the risk of colonization or risk of infection is only if the drainage procedure has not been done appropriately. Let's say what the Ajit says.
See, I cannot compare that what is the risk, because we don't have any published record on that what is as compared to the West. But I will like to just point out another factor. So about a year back, me and my other team members noticed that about 4 or 5 consecutive patients developed febrile. Of course, this is never serious. They developed fever after the procedure, and one after this thing. So we became concerned that what is happening. Cultures were sterile. So when we checked into that, we went through each and every step with our technical staff, and we realized the only change which had taken place, that the germicidal which was being used was replaced by another company, right? So these are small things, so we just switched on to the previous one and things sorted out. So what is the message out of this? That you have to be observant and cautious and pick up the things, and then you will find a solution to most of the things. But there's nothing, no technology will ever replace our manual processing.
I think meticulous cleaning manually followed by through the.
There's the two points I wanted to raise. I think they're important. One is that what has changed from Ajay and Riaz and myself. When we started doing ERCPs, we used to inject a lot, especially inject and try and opacify the whole system. For palliative procedures now, where I know that there is not much of a need, we try now, most of us try and put a wire up. After we've got a wire in, then we actually get the cannula pass into the system where you want to drain, and then you inject, which is a system which has changed now, and obviously dye injection and all. And I think that is something that for those who are listening, I think it's important to limit yourself with that, because the more dye you inject, the more likely you are going to have this problem as well. But one point, Ajay, are you in India using prophylactic antibiotics after ERCPs?
Not for everybody, but yes, in a post liver transplant biliary stricture, almost everybody has to we give a IV antibiotic on the day of the procedure and followed by another 2 days. Two, in that particular group of patients, you have to stop the immunosuppression for 2 days. The other groups in a already infected cholangitis, yes, you have to use, but just a simple stone removal without any cholangitis, or we don't. I would like to use that. My one or two of my colleagues will give a single dose of antibiotic at the time of the procedure. Post stenting, most if we spend too much of time, we have to difficult cannulation. We have to do a hilar stenting, a double stenting. Then yes, we like to use antibiotics.
What about you, Riaz?
Two questions from the audience. First question is: are there any guidelines? They have asked any PhD guidelines. I know that PhD guidelines on disinfection are not there. Are there any guidelines on reprocessing of the disposable accessories by Indian Society of Gastroenterology?
We have this position statement from the Society of GI Endoscopy of India. I'm the first author of those statements.
Yes, I've seen your.
And part of that I have presented here.
And what solution are you using for reprocessing of ERCP accessories?
This is the same, glutaldehyde.
Glutaldehyde. Okay, there's a question from Dr. Nadeem. Are there any studies or data on transmission of viral hepatitis through endoscopes, unsterilized endoscopes?
Unsterilized.
Unsterilized endoscopes, first thing is that, well, there are some case reports earlier on, right? Mainly the initial reports were salmonella and some of pseudomonas. But yes, there are obvious occasional case reports of this thing. But nowadays, nobody will use it as an unsterilized scope. It may be improperly sterilized, let me put it like that. Improperly or inadequately sterilized scope. Maybe that's the question that they wanted to ask.
Correct.
Yes.
May I add there? I think the issue is more with biopsy forceps, which we use without, quite often without autoclaving. And that is, I think, a bigger source. Because endoscopes are blunt, by and large, gastroscope or colonoscope, the chances of transmission of these viral diseases is, if anything, almost zero. You will have case reports, but the problem is, how do you determine in a country like Pakistan, where you have 5% prevalence of Hep C and 3% of Hep B, how are you going to know whether it is actually transmitted by this, or unless somebody had an acute hepatitis episode? I haven't seen that. I don't know. Riaz saab ne dekha hai, aapne,
not really, not really.
Not.
And I'd like to mention that the standard reprocessing or re-sterilization procedure, which is recommended for the endoscope, takes care of almost all the viruses, bacteria, parasites, and including mycobacteria. HIV and all is taken care of. And just I'll add a piece of information that we are in the era of automatic reprocessors, but the manual cleaning in the world WHO recommendations, I'm a co-author of that, and we have clearly said that manual cleaning, which is being done by a single endoscopic centers, a lot of centers in our part of the world are equally competent if they have adhered to the guidelines properly. That is one. Secondly, I like to add here that we have done manual cleaning of the endoscope after endoscopy in a COVID positive patient. And we have tested it for COVID, the scope, for the proper protocol post procedure after the manual cleaning. And we have found it to be effective in all the 5 cases. We are reporting that. And so it is safe, even if you're doing manual cleaning and you're following the proper manual cleaning. The question is proper meticulous cleaning.
I think the emphasis is one question, Riaz, about in case of endoscopy related infection, what should be the protocol?
Yeah, that's what I was going to ask. what should be the protocol, or what protocol does your department use in case infection following the ERCP is reported in your department?
You see, protocol as before, I mean, we'll go back and check our culture reports of the previous one, or there is any breach of protocol. That is one part. Secondly, there are cases where will be inherent, there is an inadequate drainage. And our observation is almost 9 out of 10 cases, if this happen in the say like, will be due to improper drainage, blockage of the stent, migration of the stent, and so on. And so you take care of that part and things will sort out.
Saad, do you want to say something?
I think, about this, the same question.
No.
Generally. Yeah, I think, no, I think, Ajay, you've covered the whole thing very nicely. I think the most important point that comes across is the fact that, yes, you can use and you can continue using for our part of the world. But the most important thing is to follow the cleaning guidelines, the sterilizing guidelines, and the disinfecting guidelines. And I think one of the things that I'm sure we're going to start in our unit would be a CME for our techs, and that can be spread over to for other techs and other hospitals as well. I still am skeptical that using a disposable scope is completely going to get rid of this very small number of patients that we get. I am not too sure. I believe that once you've inserted the accessory, your hands become non-sterile. You are manipulating the wire, you have a non-sterile hand. So this concept about this whole thing being sterile, completely sterile and completely infection-free, I doubt. We are doing far more therapeutic procedures now, far more advanced procedures now, and hence I think we're seeing more problems as well. So I may be on the cynical side of this where I feel that this is being driven by industry, like many other things, like the disposable accessories themselves. They are driven by industry. They make a lot of money out of it, which is fine. But I think in our part of the world becomes a little too much. I was just looking at Spyglass forceps. That's a whopping 200 some thousand rupees, and it doesn't last. So it's
at the most.
all these accessories are extremely expensive when you're working here in our part of the world. So we'll have to be different. I think we can learn from India a lot, and I'm sure the Indians can hopefully have some learning from our side as well. And we must work on this. I think we have to have some kind of a properly done study.
We need to have more forums amongst each other. So we need to have more forums amongst each other to learn from each other.
Absolutely.
Because the same conversion of the dollars to Pak rupees or Indian rupees, that turns into a huge amount of money, and not many people in the two countries can afford that. And since we already overspent 3 minutes, I'm really thankful to Ajay Kumar for sparing his precious moments. And he has given a very nice elaborate talk on the two topics. One is endoscope and the other one is reprocessing of the endoscopic accessories. Yes. I'm really thankful to my co-panelist, Dr. Saad Niaz, Dr. Junaid, and I'm thankful to Wilson Pharmaceutical and all the other supporting units which has sponsored us for this webinar session. Ajay, thank you very much. And thank you to your family for given you the time on Sunday for talking to us on a very important topic. I hope that you'll keep speaking to us on this forum, and if you permit me, I can keep bothering you on the similar topics in future as well.
Anytime. It will be a pleasure, and I've really enjoyed it.
Thank
and
you.
actually to touch base with both Saad and Tayyab after a long time. It's been really nice.
Thank you. It was really nice catching up, and I'm really thankful to Wilson Pharmaceutical for providing us platform for.
Come and have kebabs there.
Thank you so much.
Let's hope that you're able to come to Lahore, and we'll happy to serve you with the most delicious kebabs of Lahore.
Yes.
Okay. Thank you very much, and goodbye to everyone, and see you next Sunday with training opportunities in endoscopic ultrasound, and Lawrence So is going to speak on this topic. Bye bye. Assalamu alaikum.